Now let us begin with the first component of a cast partial denture. We will begin with the components of metal framework first, and the most important part of it is called as your major connector. Now let us define what major connectors are. A major connector is a component of partial denture that connects parts of the prosthesis located on one side of the arch with the parts located on other side of the arch. So the main part that one must understand is it has the role of connection, as the name suggests, that it will connect the components which are located on one half of the arch with the components on the other half of the arch. It is that unit of the partial denture to which all parts are either directly or indirectly connected. So either directly or indirectly through your minor connector also, the different components are connected to your major connector. Now, any major connector, like any other component, also has some desirable characteristics. So let us look into those right now. What are desirable features of a major connector? The first desirable feature is it should be rigid in nature. Now, this is something that you must understand. Whenever any occlusal forces are applied onto the prosthesis, if the main connector of your prosthesis is rigid, the forces will be dissipated from the point of application. Point of application would usually be your acrylic teeth that are replacing the partially edentulous arches, right? Wherever your natural teeth was and now you have an artificial tooth over it, majority there is where the concentration of occlusal force is. Now, if the under support is completely rigid, once you have a point of application of load, it will have a complete dissipation of the load. That means uniformly the load will be shared amongst the prosthesis. But when you have a flexible prosthesis or a flexible major connector, such as which is made not of metal but say of acrylic, the tendency is that wherever the point of application is, that point will flex and bend, and it will take the load at their majority and only less of it will be dissipated to the adjoining structures. The downside of it is that over a period of time, this kind of acrylic prosthesis will have accelerated resorption because one single point is taking or one single area is taking the brunt of the entire occlusal force. So there will be dissimilar resorption and loss of even that abutment or loss of that particular bony structure. So by accelerated resorption. So that is the difference, and which is why it is said that a cast partial denture is your definitive prosthesis because it has a metal framework that makes the substructure of the prosthesis. So rigidity is an absolute necessary feature of a major connector, and that is the first desirable feature. Second feature is that it should be compatible or biocompatible with the oral tissues. It should not cause allergic reactions to the oral tissues. Third is it should not interfere with the tongue. Fourth point is it should not alter the palatal contour substantially. So whatever is your prosthesis design, that design should not alter or change the shape of the palatal contour. Say it is U-shaped, you should not make it V-shaped, because that will be difficult for the patient to transition also, plus the tongue will continuously touch and interfere over there. So it should not alter your palatal contour. This is point number 4 for us. Point number 5 is it should be constructed in a way that it does not impinge on oral tissues. Point number 6, it should cover only areas which are necessary. Unnecessary extension should be avoided. Also, it should not allow food trapping. So, design of the prosthesis should be such that food should not be trapped into the prosthesis, or different pockets should not be formed where food trapping occurs. Also, it should support the prosthesis. So, design should be such that it provides support to your prosthesis. So, all in all, these are my different 8 desirable features for a major connector. Now, let us begin with first the maxillary major connectors and some common design principles that are applicable to all maxillary major connectors. Previously, we saw different 8 features of a major connector that are applicable to maxilla as well as your mandible. Specifically now to all maxillary major connectors, some design principles are applicable. They are, as we discussed right now. The first principle that we apply over here is you should maintain a 6 millimeter relief for marginal gingiva. Now, in any maxillary major connector, one must maintain a distance of 6 millimeter between the superior border of the maxillary major connector and your marginal gingiva. Reason for this is that marginal gingiva by itself is thin and a friable tissue. So, because it is thin and friable, that is prone for damage or say injury very easily. It is a highly vascular tissue also. So, because of this, it is said that you must provide at least 6 millimeter distance from the marginal gingiva so that there is adequate relief for it. Apart from that, if we look at different structural requirements also, we can notice that the borders are smooth and well rounded. There are no sharp projections on the major connectors and the borders are smooth and well rounded. That is for so that it does not damage the underlying tissue. But the main structure that one has to see is that it should be 6 millimeters away from your marginal gingiva. That is applicable over here as well. That is applicable over here as well. That is the main function of it. Now, pro tip or a pro question here is try and identify different Kennedy classifications in the images that you see in the subsequent slides. That will help you get a hang of your Kennedy's classification. So, just a side note from your main topic that we are discussing is that this particular arch, as you see, it is what? Think to yourself, is it Kennedy class 1 or a Kennedy class 2? This is a Kennedy class 2 situation. Right? So, this is your Kennedy class 2 situation, and the part that I'm highlighting in green, that is my maxillary major connector. Now, there are about 6 different types of maxillary major connector. So, let us understand types of maxillary major connectors. First is called as single palatal bar. Second variety is called as single palatal strap. Now, subsequent ones are a combination of these. So, you have anterior, posterior, palatal bar, and you have antero-posterior palatal strap. Then you have something which is called as a U-shaped or a horseshoe shaped connector. And lastly, the one that completely covers your palate, that is called as complete palate. So all in all, we have 6 different varieties of your maxillary major connectors. Now we will look into all of these one by one and we'll understand what is the difference between a bar and a strap. Now a pro tip over here that I can give you is just try to learn the difference between what is a bar and what is a strap. All of the different major connectors are a permutation of bar and strap. And if you know what is an advantage of a bar and what is the advantage of a strap, then you would be able to understand all of them and subsequently check the indications of them. Now, let us look at questions that can arise out of this part. Now, the question that arises, the long question that comes in exam for all our university students is maxillary major connectors. You have to describe the definition, classification, and maybe they may ask you to describe 1 or 2 connectors or maybe all of them in detail if it is a long question. Short question that can arise out of it could be, say, antero-posterior, palatal bar or strap. So, or any one major connector. That could be your short question. Now, for all my fellow NEET students, the questions or MCQ that can arise are what? From the ideal requirements, I don't see many questions being formed out of it. But the one MCQ that comes is the distance of relief for marginal gingiva, and the answer, as we all know, is 6 millimeters. So that is a fair question that can arise out of this topic. Again, when we learn mandible, I'll tell you over there also, but just for the contrast over here, you can remember in maxilla it is 6 millimeters, in mandible it is 3 millimeters of relief for your marginal gingiva. Now let us begin with the first maxillary major connector that we are going to study. It is a single palatal bar. Let us understand what a single palatal bar is by its definition here, that a palatal connector or a palatal major connector which is less than 8 millimeters in width is referred to as a bar. So the dimensions of this connector, they are less than 8 millimeters. The key point that one has to remember is width is less than 8 millimeters. That is called as a bar. Now, all my dear students would understand that a bar will always be slightly thicker in cross section, and the shape of that particular cross section is, it is narrow and half oval. So oval is somewhat like this, right? When you do half of it, then this part is called as a half oval cross section. So half oval would be this cross section. Now in this half oval, the flat part is towards the tissue and the rounded part is towards the oral cavity. The flatter part is adapted along the palate or your tissue part, and the rounded part will be towards your oral cavity. So the tongue can feel the rounded part of the palatal connector. The thickest part of this connector is located at the center of it. So when you can see over here in the cross section, this is the thickest part at the center. Now, what are indications of these? Which means where are we going to use your single palatal bar? Indications are limited to replacing 1 to 2 teeth on either side of the arches and no further anterior than second premolar position. So from this, what we derive is this is used for Kennedy's class 3, or it can be even used for Kennedy's class 3 modification space 1. But in both of them, the requisite is that it should be just single or even 1 to 2 teeth missing, not more than that. That is a point that one should remember. Another point which is key over here is it should be no further than the second premolar position. So as we refer over here in the image, it should not be located anteriorly further in the arch. The reason is the presence of rugae, as you can see. When you have rugae anterior to second premolar, presence or adaptation of this bar is difficult, plus it will interfere with your phonetics function. Now let us look at some contraindications of single palatal bar. The first contraindication is any distal extension situation. So from distal extension, we mean Kennedy class 1 and Kennedy class 2. Now, as a side note over here, for all those who do not understand what distal extension mean, any partial edentulous arch which does not have natural teeth located posterior to it, that is the distal most partial edentulous space in the arch, is also called in loose terminologies as distal extension case. It could be unilateral or bilateral. So class 1 and 2 of Kennedy come under your distal extension situation. Second contraindication is when anteriors are missing. So since utilization of a single palatal bar anterior to second premolar is not possible, then you cannot utilize it for replacing your missing anterior teeth. So as we have looked in the image over here, it can be utilized to replace 1 to 2 missing teeth on the either side of your arch. Now let us look at some of the disadvantages of a single palatal bar. The first disadvantage is it is most difficult to adjust for your patient. Because of its thickness and cross section, there will always be a foreign body sensation in the palate of your patient, and it is very difficult for your patient to get accommodated to this prosthesis. Second is it derives little to no support, no vertical support from the arch. Therefore, mainly it has to rely on rests on your natural abutment teeth. Since its coverage is less, its span coverage is less on the palate, it will derive little to no vertical support from the palate, mainly has to rely on support for your natural abutment teeth. So these are all of the different points that are pertaining to your single palatal bar. It is a old design, not used very frequently, and mainly now clinically I'll tell you where is it indicated. So clinically, if I say where single palatal bar is indicated, it would be for your interim partial dentures. That is one of the indications of your single palatal bar. Interim partial dentures of replacing 1 to 2 teeth on either side of the arch. That is single straightforward line that one needs to remember from single palatal bar. So all in all, if we just revise your single palatal bar, what are my key points for MCQs or otherwise that I need to remember? It is less than 8 millimeters in width. It is half oval in cross section, and it is used for class 3 situations with 1 to 2 teeth missing on either side of the arch. And the biggest disadvantage is that it is discomfort to the patient. It causes discomfort and poor actually compliance from your patient. So these are just 4 points that can revise your complete single palatal bar for you. Now, after discussing single palatal bar, let us come to the second maxillary major connector, which is called as single palatal strap. Single palatal strap comprises of a wide, thin band of metal that crosses the palate in an unobstructive manner, which means there are no breaks in it. It crosses the palate in one go. The word that we need to remember here, it is a wide and a thin band of metal. Now, a single palatal strap is never less than 8 millimeters in width. So always remember it has to be greater than 8 millimeters in width. That is one of the key points for your single palatal strap. Now, why is it so? We are talking about this width over here. Why is it so? Because it is thinner in cross section and flatter. We need that so as to maintain rigidity of your prosthesis. So that is your single palatal strap. Now, what are some advantages of it? Now, when are we discussing the advantages, I must tell you that these all advantages are in comparison to actually the previous major connector. So, in contrast with a single palatal bar, a single palatal strap is better tolerated by your patient. Because the single palatal bar was thicker in comparison to that, it is better tolerated by your patient. Second advantage is that since it is flatter and located in multiple planes, it will provide you better resistance to bending and twisting. So that is a advantage of your single palatal strap. Now come to indications of single palatal strap. The first indication is only again when 1 to 2 teeth are missing. So these are all your Kennedy's class 3 situation cases where 1 to 2 teeth are missing on either side of the arch, where need for palatal support is minimum. In all of these cases, you can utilize your single palatal strap. Comparatively with a single palatal bar, tolerance of single palatal strap is much better and hence it will be preferred over it in clinical situations. Now, what are contraindications of a single palatal strap? The first contraindication is when anteriors are missing and when you have distal extension cases. So when anterior teeth are missing, again because of its location located posteriorly behind second premolar, you will not be able to utilize your single palatal strap. Also, because it is slightly deriving lesser support from the palate because of the size of the strap, you will not be able to derive enough support that is needed for a distal extension situation. So all in all, if we now revise, a single palatal strap, it is always greater than 8 millimeters in width and used for Kennedy class 3 situation. Contraindications are the same and better tolerated than your bar, right? So the key points are listed over here. So this is your single palatal bar and your single palatal strap. Now let us begin with the third variety of maxillary major connector, which is your anterior-posterior palatal bar. As the name suggests, it is a combination of two bars. One is your anterior bar and one is your posterior bar. Now anterior bar is slightly flatter and narrower in comparison to the posterior bar, and it is located in the valleys between the rugae. Let us identify that in the image over here. You can see that this is your anterior bar, narrower than your posterior bar. Again, it is located in the valleys between your rugae. Posterior bar now is half oval. That means like this. It is half oval in cross section and it is located posteriorly in the arch. It is slightly bulkier than your anterior bar. Anterior bar was flatter in design. These two bars, how are they united? They are united by flat longitudinal elements. So when we see it in the picture over here, the flatter longitudinal elements are highlighted by blue, and they are these elements that you can see. Similarly over here, highlighting them by blue, these are your flat longitudinal elements. Together, they form something which is called as the L-beam effect. Now, what does L-beam effect mean? L-beam effect is a civil engineering principle in the room that you're sitting right now. If you look at the corner, you will find something which is called as a beam or a column. When the column or the beam are located at an angle to each other like this and in different planes, rather than increasing the size or thickness of it because of its spatial orientation in 2 or 3 different planes like this, it will add to the rigidity and support of the structure. This particular principle of civil engineering is called as an L-beam effect. If you identify the same over here in our prosthesis, we can see that maxillary palate is generally, as I'm drawing over here, U shape like this. Now, for our understanding, I can just translate it into 3 different planes. This slope of the palate, this horizontal part of the palate, and the other slope of the palate. What we are trying to tell here is when a structure is located in 3 different slopes like this, or if I refine and tell you, if it is located in 3 different planes like this, it is going to add to rigidity of that structure. It will prevent torsional bending as well as any bending of the prosthesis against application of forces. So that is happening because your anterior and your posterior bar are uniting at an angle and forming the L-shaped structure. Also, one has to notice is that the center of the prosthesis is giving something which is called as a circular effect that also adds to the rigidity of the prosthesis. Now let us look at the indications. So what are the indications of this? When anterior and posterior abutments are widely separated. So I have an image here to support it. As you can visualize over here, I'm going to mark all edentulous areas in purple. You can see one area over here, you can see one area over here, then another areas that are located anteriorly. Now you can see there are multiple small edentulous spaces and the abutments are widely separated like this. At that point of time, a single palatal bar or a strap is not going to be of any help for you, and you need a larger major connector design from which your minor connector and other components can emerge. So that design is your anterior-posterior palatal bar. So that makes up the first indication of it, which is anterior and posterior abutments being widely separated. Second indication, very important, is presence of torus palatinus. Now we all know that torus palatinus is an exostosis of the bone usually formed in the center of the palate. It is however more common in mandible as torus mandibularis, but we still see it in a lot of patients. Now when that structure is present in the center of the palate, you cannot cross over it, especially when it is larger in size. In that case, when you have to exclude it from the design of a prosthesis, a anterior and posterior palatal bar is going to be of much help to you, because your torus palatinus can be accommodated in the center over here and excluded comfortably from the design. So, presence of torus, second indication. Third is for, say, distal extension cases where abutments are strong, providing adequate support. It can also be used for your class 4 cases where anteriors are missing. So try and understand that a particular edentulous arch, now since we are transitioning to the further much more vaster design of major connectors, there is a very important principle that is used for I would say indicating a particular major connector is the property of support. The support can be derived from abutment, it can be derived from tissue also. Any case will always have a need for support on the basis of how many teeth are missing. If lesser teeth are missing, need of support is less. If more teeth are missing, need of support is more. If your tissue is fulfilling that major need for you, then it will be a more tissue supported prosthesis. And if your abutments are strong, healthy, and can provide you with very good support in that situation, you will have a more abutment supported prosthesis. So, in that situation, you would be having a less coverage of the major connector on the palate, and you will have a smaller design or smaller coverage of that major connector. So, maybe more teeth may be missing, but because abutments are providing you with adequate support, in that situation, you can use a smaller or less coverage design such as AP bar or an AP strap in comparison to say something which is a complete palate. So, because your abutment are providing you with excellent support, you can use a lesser coverage and lesser support from the tissue over here and utilize maybe AP bar or AP strap. So that is why I say that patients with say mental attitude that I don't want complete coverage of the palate. I don't want a completely covered full palate that gives me gagging sensation. Well, that is uncomfortable. And you find that abutment are very good to provide you support. Do not completely cover the palate. You can use a less coverage design such as AP bar, or you could even use AP strap in those situations. So these are your indications of the prosthesis. Coming to contraindications of AP bar, the first contraindication is an extension of what we discussed right now. Reduced periodontal support of abutment, and your support requirement is more, then you need to cover the tissue more. So reduce periodontal support of your abutment teeth, right? So these are indications and contraindications of your AP bar. Now come, let us see advantages and some disadvantages of AP bar. Now here I would like to bring you back to your previous topic of single palatal bar and remember its disadvantage. The disadvantage that will be applicable over here also. Now first let us look at the advantage. Because of its L-beam effect, it will have excellent rigidity. Second advantage is lesser coverage of maxilla. That is in comparison to a complete palate. You have lesser coverage of maxilla. So that is an advantage. Now we look at disadvantage and remember it from single palatal bar. What was your disadvantage? Because of the design of bar is objectionable to your patient. So it is frequently uncomfortable to your patient. Second is still it derives lesser support from the palate. So you will have more dependency on your abutment teeth. And third is may interfere with speech because of the anterior bar. So that is the third disadvantage of your AP bar. So let us quickly revise our antero-posterior palatal bar. We have a anterior bar which is flatter. We have a posterior bar that is half oval in the cross section. It has something which is L-beam effect that gives you very good rigidity. And the most important indication of it is in the presence of torus palatinus. You can definitely utilize this. So all in all, these are some key points pertaining to antero-posterior palatal bar. Now let us discuss the fourth design of your maxillary major connector, which is called as antero-posterior palatal strap. Very similar to antero-posterior palatal bar, instead of the bar, you will now have a strap. Again, like I discussed previously, it will have two components, an anterior strap and a posterior strap. Now, anterior strap is flat and it should be minimum of 8 millimeters wide. So if we look at in the figure over here, this particular width should be minimum 8 millimeters. It should not be less than that. The reason we all know is that it will compromise the rigidity of your prosthesis. Again, you will have a posterior palatal connector also, which is this part should be located as far posteriorly as possible to avoid interference with the tongue. Now, a lot of features, design features remain the same, which means that L-beam effect is applicable here as well. And this will enhance rigidity of the prosthesis. The chief difference that arises is from the presence of the strap instead of the presence of a bar. And you can very well guess that when you have a strap in comparison to bar, what advantages would you have? So let us look at those advantages. First advantage would be excellent rigidity because of your L-beam effect. Second advantage is increased patient comfort. You have a very good patient comfort with this because the bar is a half oval cross section, thicker in cross section, difficult for the patient to adapt to. Whereas if we see a strap is thin piece of metal, so the tongue will not cause much of interference. The third advantage, it has a wide range of indications. In a lot of clinical situations, you can apply your AP strap. So these are your advantages of AP strap. But with your advantages, there are some always disadvantages as well. So let us look at the disadvantages of AP strap. The first disadvantage is that although the metal will be thinner near the root area, but it may interfere with phonetics. And it still has significant coverage of the palate in comparison to a single bar or a strap. So there is a good chance that it can lead to inflammation of the tissue underneath it if hygiene is not maintained. It can also lead to, when there is multiple coverage of the tooth, demineralization of the tooth structure also. Now, after looking at the disadvantages, disadvantage and advantages, let us look where we can apply AP strap. Remember here, do not overcomplicate. A single palatal bar and strap fairly have similar indications. An anterior-posterior bar and strap also have similar indications. So what would they be? Indication number 1 is all your distal extension cases. Indication number 2 is all your class 4 situations. Any case of presence of inoperable palatal torus, you can use AP strap, same as your AP bar only. So all your distal extension cases, whether it is class 1, class 2 with a modification space, widely spaced abutments, all of these situations you can use AP strap also in the presence of an inoperable torus. So all in all, if as a student I have to remember AP strap, how do I remember it? Majority of it is the same as AP bar, except that the strap are greater than 8 millimeters wide. And the only differentiating point is it offers better comfort. If as a clinician I am asked what would I choose, I'll definitely choose AP strap in comparison to an AP bar because of the additional comfort that it gives to the patient. Apart from that, I'm not listing all other points because they are not the differentiating points from AP bar. They are the same as that, and that you can remember cumulatively over here. Now, let us next proceed further with the fifth maxillary major connector. This is called as a horseshoe shaped major connector, also known as a U-shaped palatal connector. What is it? As the name derives, it resembles a horseshoe like this. That is why it is called as a U-shaped or a horseshoe-shaped connector. So very similar to your AP strap, except that the posterior palatal connector is missing over here. This comprises of a thin strap of metal running along the posterior teeth. This comprises of a thin strap of metal running along the posterior teeth and onto palatal tissues. The borders of the horseshoe connector must be 6 mm away from the marginal gingiva. Very specifically mentioned over here because it is a key design principle for a U-shaped connector. Borders should also be placed in valleys of the rugae. And the lateral borders, where should they be? Lateral borders are placed at the junction of horizontal and vertical slopes of your palate. So let us all see this over this particular image. It comprises of this wide band of metal that runs along the posterior surface. It can even extend onto the tissue by 6 to 8 millimeters. If you want to slightly increase the rigidity, extend its coverage onto the palatal tissues more, which means you slightly extend over this horizontal part of it slightly more, right? Apart from that, if you notice, it runs along the posterior surfaces. It has to maintain this 6 millimeter distance from the marginal gingiva, which is absolutely necessary. Apart from that, it should always be present in the valleys of the rugae over here anteriorly. It should not interfere with the elevations of the rugae. Now, where is a U-shaped connector indicated? It is a very specific question and an indication which is asked in exam. So, what are the indications of it? Indications are cases of large inoperable torus, and very specifically where this large inoperable torus extends onto soft palate. Now, usually we know that the palatal connector would be placed along the hard palate only or at the junction of hard and soft palate, but it does not cross beyond it. You cannot place it on soft palate. Now, when you have a large torus, say you have your maxilla like this, and say this is your tuberosity and the extent where the hard palate ends. I have a torus that extends onto my soft palate like this also slightly posteriorly. In that case, I have no provision to place my posterior major connector. So in those situations, you will go with a U-shaped connector like this. That is the chief and the only indication of your U-shaped connectors. Second indication, still if you want to mention and remember, is a patient of exaggerated gag reflex. When the gag reflex cannot be treated with any pharmacological or non-pharmacological means and you only have the option of a partial denture rehabilitation, you can utilize a U-shaped connector. Most important part in a U-shaped connector is learning its disadvantages. So let us look at them one by one. The most important disadvantage is the lack of rigidity. Now, I'll give you a small exercise here. Take a U-shaped metallic object, like say you have a tongue cleaner or you have an orthodontic wire that is bent as a U. And when you flex the terminal ends of it, when you bend them, it will flex inwards and it will go outwards. So it would look somewhat like this. It can flex outwards over here and it can even bend inwards also. So when something flexes like this, it does not solve the purpose of a major connector or an ideal major connector, which it is. That is why the first or the most important disadvantage is that it lacks rigidity. Second disadvantage is bulk addition may be required. Now, to counteract this loss of rigidity, sometimes you need to add bulk to the prosthesis. Bulk addition may be required. And this bulk addition will lead to the third disadvantage, which is tongue interference. So, all in all, these are the main disadvantage of it. And if we quickly revise a U-shaped major connector, if we quickly revise it, what you need to remember is minimum 8 millimeters, but more than that, it lacks rigidity. That is the main thing that one needs to remember, and its only indication is torus extending onto soft palate. That is all about your U-shaped maxillary major connector. Now let us begin with the discussion of the last of your maxillary major connector. This is called as complete palate, also known as palatal plate type maxillary major connector. Now a palatal plate type maxillary major connector is a full palate connector. And a full palate connector would be thin and follow the, or I would say replicate the natural anatomy of the palate. So it is completely as how the palatal shape should be, and it should duplicate the contours of it, including the rugae. Second is anterior border, again should be 6 millimeters away from the marginal gingiva. Posterior borders would be at the junction of hard palate and soft palate. So let us look at in the image over here. It has to be 6 millimeters away from the marginal gingiva, as we have seen here. Anteriorly, it can extend up to the cingulum of the anterior teeth, providing it adequate relief underneath. And posteriorly, it is at the junction of hard palate and soft palate. Now, this posterior border can be completely metal also, or it can be metal plus acrylic. So, if you want to do posterior damming, posterior palatal seal formation and damming, you can make it in metal plus acrylic. If you want to duplicate in acrylic, make the posterior border slightly shorter, prepare some space for acrylic, and then you can dam that area. Within the design principles of a complete palate, we incorporate a small metal bead at the posterior border of the complete palate. This is primarily done so as to maintain positive contact with the tissue. How do we prepare it? It is prepared by slight scraping of the refractory cast prior to pattern formation. So, if we look at the posterior border over here, and I take this part and I want to show it to you in a cross section, rather than maintaining it completely in flat contact with the palate, what we want to do is at the posterior border, we want it to end it into a bead like this. This is called as a bead. So to have that additional bulk or this bead at the posterior border, which is just like a thicker band of metal at the posterior border, you scrape a line in the refractory cast. When you scrape that line, a depression will be created that will be filled by wax, and eventually it will be casted by metal. So it is like a thin line or a thin thread, thick thread at the posterior border of it. That will help with the beading as well as posterior positive contact of your palatal major connector. Now let us look at the advantages of what a complete palate is. The first advantage is that it reproduces anatomic contours properly. Thereby, this will help with better tolerance and a foreign body sensation is avoided. Second is thermal conductivity. And sensation is there, which will give a positive feedback to the patient. Say you're having a hot tea or something like that. That sensation is transferred to tongue and the underlying tissues. Come, let's look at some disadvantages. First disadvantage is the adverse soft tissue reaction. We see that a lot of patients are unable to maintain hygiene underneath the prosthesis. Some patients are also systemically more inclined to get those denture irritations such as stomatitis, especially diabetic patients or immune compromised patients. In those cases, because of the excessive coverage of the palate, you may face issues. So, adverse soft tissue reaction may occur. Problems with phonetics can also occur because of the coverage of the rugae area. Right? So these are some disadvantages of it. Now let us look at the indications and then some contraindications. The first indication is all distal extension, which means class 1 and 2 cases, even the cases which have poor support from the abutment teeth. When you see flat arches or you have flabby tissue, so all of the cases where either the tissue or the abutment support is poor. In patients with cleft palate, it will prevent the ingress of fluid and other substances into the nasal cavity and act like an obturator over it. So you can utilize in cleft palate patients. And when the opposing arch is of completely dentulous mandibular teeth, natural mandibular teeth, then we anticipate that the bite force will be more in that situation. So then you have to complement it with a full coverage prosthesis. So these are the specific indications of a complete palate. Mainly in all cases where needed support is more. In that case, you can utilize complete palate. Now let us look at the contraindications of a complete palate. The only contraindication that we can think of is presence of a torus. When you have a torus which has not been surgically removed, then that is an absolute contraindication for utilizing your complete palate. So with this, let us try to revise complete palate. Complete palate is required in all cases where here support requirements are more. In your complete palate, beading is done at the posterior border. Also, in a complete palate, phonetics may be affected and you may have problems with the torus, so it is contraindicated in torus. And the chief indication of a complete palate is all your distal extension cases. So this is an overview of your complete palate. With this, we complete all the 6 varieties of maxillary major connectors. The questions that can now arise out of them, let us have a look at it. Like I discussed early on at the beginning also, the question that can arise is a long question on your maxillary major connectors and a short question on any major connector. This is for your final BDS students, and for our NEET students, MCQs what can arise? First is numbers or values, which means your width of strap or distance from marginal gingiva. This is your 6 millimeters, this is 8 millimeters minimum, all of these numbers and values. And second most important questions are indications. What is the indication? Most important question that comes out of indication is the indication of a U-shaped palatal connector. Third question that is of contraindications that are chiefly pertaining to torus only. Contraindications are usually pertaining to torus. So a small tip that I can give you is you have to highlight and remember which major connector is used in the cases of torus. So restructure and re-engineer it. What can be used in torus, what cannot be used in torus, and try to remember in that way. So that is how you even revise your topic. So with this, we complete maxillary major connectors. That is the first set of major connectors.